we'll be breaking down all major concepts covered on the exam.
Right, because as MCCQE reviewers, our entire focus is really just helping Canadian medical students master this material, and honestly, feeling completely confident when you walk into test day.
Exactly. You've got to have that confidence. And our specific mission for this deep dive is uh, tackling a very high yield but deeply complex topic in pain syndromes, specifically for section S08 neurology.
Yeah, we're analyzing complex regional pain syndrome, or CRPS.
Yeah, CRPS. And real quick, before we get into the weeds, the concepts we're teaching today are drawn directly from reliable StatPearls articles.
Absolutely. And, please remember this deep dive is strictly for medical education. It's not medical advice, right? So clinical decisions should, of course, always involve a qualified healthcare provider.
Disclaimer aside, let's set the scene for you. Imagine a patient comes into your clinic. They suffered like a simple wrist fracture a few months ago, or maybe they just had a routine IV line placed during a quick hospital stay.
Right, something super common.
Yeah, incredibly common. And the tissue is healed perfectly. The bone is set. But instead of returning to baseline, they are experiencing this just devastating cascade of pain that far outlasts the actual injury.
It's awful.
It really is. The skin is changing colors, the limb is swelling, and like a light breeze against their arm causes them to scream in agony.
Yeah, and it's a clinical presentation that can be incredibly distressing for the patient, obviously, but frankly, it's also quite baffling for the clinician if they aren't prepared to recognize the underlying mechanisms.
Right?
Because the pain isn't just lingering, it has become entirely disproportionate to that initial inciting event. It takes on a life of its own.
So before we can even discuss how to, I don't know, turn this pain off, we need to define the parameters of what this syndrome actually is, because the MCCQE absolutely loves to test your ability to differentiate it from other neuropathies.
Oh, I love it.
So at its core, CRPS is a neuropathic pain disorder, right? Characterized by that severe, disproportionate pain persisting well beyond the expected healing time. But the definitive, board-relevant feature is its distribution.
Yes.
It is regional.
That regionality is the massive differentiator. I mean, if a clinical vignette describes pain perfectly tracing the L5 dermatome,
Like a nice, neat line.
Exactly, or isolated strictly to the median nerve pathway, you should immediately question whether it's CRPS. Because CRPS favors the distal extremities, but it does not respect distinct nerve territories.
No respect for the boundaries at all.
Right. It might begin in the hand and then just spread proximally up the arm, or even cross over to the contralateral limb.
Which is wild. I always visualize CRPS like a malfunctioning car alarm, right? Normally, nociceptive pain is a functional alarm. Someone breaks the car window, the alarm blares. You fix the window, the alarm stops.
Right, normal function.
But with CRPS, the alarm keeps blaring at maximum volume long after the thief has run away and the glass is replaced. But because the pain is regional and not dermatomal, it's as if the short circuit didn't just affect that single car. It caused the alarms of every single vehicle on that entire parking garage level to go off simultaneously.
That's a great way to think about it. The entire localized network becomes hypersensitized, and building on that, the exam will heavily test your knowledge of the two primary subtypes.
Okay, let's get into the subtypes.
So type 1, which was historically known as reflex sympathetic dystrophy, occurs in the absence of any known nerve trauma.
No direct nerve trauma.
Right. The inciting event might be a sprain or a casted fracture, but there's no identifiable peripheral nerve injury. Type 2, on the other hand, formerly causalgia, occurs when there is a known distinct nerve trauma, like a crush injury that physically severs a nerve.
Okay, but wait. Sitting across from the patient in the clinic, type I and type 2 present with that exact same blazing parking garage alarm.
Right.
Clinically, they're indistinguishable.
Completely indistinguishable on presentation, yes.
So that means the only way to tell them apart in an exam vignette is by meticulously combing through the patient's history for a mechanism of direct nerve trauma. That's the only way.
That is the way. You are looking for the mechanism of injury in the prompt. Now, you might also see modifiers like warm versus cold, CRPS, indicating the vasomotor state, or sympathetically maintained pain versus sympathetically independent pain.
Okay.
And those affect prognosis, but distinguishing type I from type 2 is the primary categorization you absolutely must lock down for the test.
Okay, so since this widespread alarm system is indiscriminately firing across an entire region, we really need to understand what actually short-circuits the wiring in the first place.
Yeah.
Because grasping the chaotic pathophysiology here makes memorizing the massive list of clinical symptoms infinitely easier.
It really does.
So fractures are the most common trigger.
Correct, by a wide margin. A large multi-center prospective study found that nearly 48.5% of patients develop CRPS following a single fracture of the ankle, wrist, scaphoid, or fifth metatarsal.
Almost half. Wow.
Yeah. And surgeries such as carpal tunnel releases or distal radius reductions, those are also major culprits.
But here is the board trap, right? Assuming the trauma has to be severe.
Oh, yeah.
The inciting event can be completely innocuous, like prolonged immobilization or a minor phlebotomy stick. It's the body's reaction that creates the disease state. The pathophysiology isn't just one pathway failing. It's a multifactorial pileup of 4 distinct mechanisms occurring simultaneously.
Yeah, so let's break down those 4 pathophysiological buckets because you need to know these.
Okay, bucket number 1.
The first is inflammatory. The initial injury triggers a massive, unregulated release of pro-inflammatory cytokines, specifically TNF-alpha and interleukin-1b, alongside neuropeptides like substance P and calcitonin gene-related peptide, or CGRP.
Right.
This whole cascade causes severe neurogenic inflammation, leading to vasodilation and protein extravasation into the tissue.
Okay, so that's the swelling and redness. Bucket number 2 is immunological. The system literally turns on itself. Patients develop autoantibodies against their own autonomic receptors.
Exactly.
Specifically the beta-2 and alpha-1a adrenergic receptors. The immune system is essentially dismantling the body's vascular regulatory hardware.
Which is terrifying. And then the third bucket is where the chronicity really sets in. Peripheral and central sensitization, which is driven by profound neuroplasticity.
This part is fascinating.
It is. So that inflammatory soup in the periphery lowers the stimulation threshold of the nociceptors. They start firing constantly. This continuous barrage of pain signals hits the dorsal horn of the spinal cord, activating NMDA receptors.
Right, NMDA receptor.
Yeah. The magnesium plug in the NMDA receptor gets cleared out, leading to a massive calcium influx, a phenomenon called wind-up. The central nervous system just becomes wildly hyperexcitable.
Okay, I want to challenge a specific point in the sources here because it sounds like literal science fiction.
Oh, I know where you're going with this.
The literature states this central sensitization gets so severe that it causes physical cortical reorganization, meaning the area of the somatosensory cortex mapping to the affected limb literally shrinks.
Yes.
How does a localized wrist fracture biologically cause the brain map to physically diminish? That's insane.
It sounds wild, I know, but it comes down to neuroplasticity and the use it or lose it principle of the brain, combined with pain interference. Because the limb is in agonizing pain, the patient stops moving it entirely.
Okay, that makes sense.
Simultaneously, the persistent, chaotic, nociceptive input essentially scrambles the normal sensory feedback loop. The brain's homunculus, the physical representation of the body and the cortex, it relies on clear, consistent tactile and motor feedback to maintain its borders.
Right.
When that feedback is replaced by nothing but chaotic, static, and immobilization, the cortical territory dedicated to that limb actually atrophies. It literally gets encroached upon by neighboring representations.
So the brain literally rewires itself to ignore the static.
Exactly.
Fascinating. And that brings us to the fourth bucket, autonomic dysregulation. We see sympathetic afferent coupling, where sympathetic receptors are inappropriately upregulated on pain-sensing nerve fibers.
Right.
So the body's basic fight-or-flight sympathetic response starts directly pulling the trigger on pain fibers.
Yes. So for you listening, if you get a question asking for the underlying mechanism of CRPS, the trap is looking for a single, simple answer.
Don't do it.
Right. You must look for answers that acknowledge this multifactorial nature, particularly highlighting central sensitization and neuroplasticity. Do not let a distractor option box you into thinking it's exclusively an inflammatory issue or exclusively a compressive neuropathy.
Because the central nervous system is literally rewiring itself into this state of hyperexcitability, patients don't just present with standard nociceptive pain. They present with this chaotic mix of systemic failures.
Total chaos.
Yeah, allodynia, where just a bed sheet touching their leg is agonizing. Massive sweating abnormalities and wild temperature swings where the hand is, burning red 1 minute and freezing blue the next.
They even suffer systemic complications like neuropsychological deficits and gastrointestinal dysmotility because the entire autonomic nervous system is just under immense strain.
And that sheer volume of multi-system chaos makes the condition incredibly hard to pin down in reality, which is exactly why the boards will test your knowledge of the Budapest criteria.
The famous Budapest criteria.
Yeah, the strict clinical threshold used to officially diagnose CRPS. Now, instead of viewing it as a random checklist, I like to think of the Budapest criteria as troubleshooting a breached electrical grid.
Oh, I like that.
Yeah, if you're the lead engineer diagnosing a total grid failure, you can't just point to one blown fuse. You have to prove that specific separate sectors of the infrastructure are malfunctioning.
That is a perfect framework.
Yeah.
Because to even begin the diagnostic workup, the mandatory primary criteria is that the patient must have continuing pain disproportionate to the inciting event. That is the baseline indication that the grid is overloaded.
Right. And from there, the patient must report at least one symptom in 3 of 4 specific sectors, and the clinician must physically observe at least one sign in 2 of those 4 sectors at the time of evaluation.
So 3 symptoms, 2 signs.
Exactly. Let's map those 4 sectors directly back to the pathophysiology buckets we just discussed.
Okay, so sector 1 is sensory. Reporting or showing signs of hyperalgesia or allodynia. This directly reflects that peripheral and central sensitization bucket where the NMDA receptors are stuck open.
Yep.
Sector 2 is vasomotor. Reports or signs of temperature asymmetry or skin color changes. This maps to the immunological bucket where autoantibodies are attacking the alpha-1A adrenergic receptors, disrupting normal vascular constriction and dilation.
Right. And then sector 3 is pseudomotor or edema. So swelling or sweating changes. This links back to the inflammatory bucket where substance P and cytokines are causing massive tissue extravasation.
Spot on.
And finally, sector 4 is motor or trophic. Decreased range of motion, weakness, tremor, or changes in hair, nail, or skin growth. This is the outward manifestation of the cortical reorganization and autonomic failure.
So again, 3 symptoms reported, 2 signs observed across those 4 categories, and the final requirement for the diagnosis, and this is key, there is no other diagnosis that better explains these signs and symptoms.
Right, it's a diagnosis of exclusion.
Exactly. If a deep vein thrombosis, a localized cellulitis, or a small fiber neuropathy perfectly explains the presentation, it is not CRPS.
And this brings up a massive exam trap. So you are reading a vignette about a patient with a swollen, agonizingly painful hand after a minor trauma. You're looking for the next best step for diagnosis. Sitting in the answer choices is a triple-phase bone scan.
Oh, they love that one.
It looks highly clinical and very tempting.
It's a classic distractor. I mean, a triple-phase bone scan can indeed show characteristic changes in CRPS, like periticular uptake, and a clinician might order one in reality to rule out other pathology. However, there is no gold standard imaging or laboratory test for CRPS. The diagnosis is purely clinical, based entirely on the Budapest criteria. If the question asks for the gold standard diagnostic test, the answer is always clinical evaluation.
Always clinical. So once you've utilized the clinical criteria to identify that the systemic grid is failing, the exam will test your next steps. Delaying treatment allows that central sensitization to really cement itself, leading to irreversible poor outcomes.
Yeah, you have to be aggressive.
Managing this requires an immediate multimodal approach.
And physical and occupational therapy form the absolute cornerstone of treatment. And we aren't just talking about traditional strength training here. We utilize highly specific protocols like graded motor imagery and mirror therapy.
And this ties directly back to that cortical reorganization concept, right? Graded motor imagery physically rewires the brain.
It does.
It starts with laterality training, like simply asking the patient to identify left versus right limbs in flashcards, which fires up the premotor cortex without triggering the pain network. Then it progresses to imagine movements, and finally, mirror therapy.
Yeah, mirror therapy is amazing. By placing the affected limb hidden behind a mirror and having the patient move their healthy limb in front of the reflection, the visual cortex sees a healthy, pain-free limb moving normally.
Wow.
This visual input feeds back into the somatosensory cortex, literally tricking the brain into re-expanding the shrunken cortical map of the affected limb. It breaks the pain spasm pain cycle at a neurological level.
It's just incredible. And alongside PT, we have pharmacotherapy. We use anti-inflammatories like oral prednisone, which have shown efficacy, particularly in post-stroke CRPS. We also use bisphosphonates.
Yes.
Now, it's always slightly surprising to see bisphosphonates on a neurology treatment algorithm, since we usually associate them with osteoclast inhibition and osteoporosis. Why are they effective for neuropathic pain here?
It's a great clinical question. So in the context of CRPS, particularly type I, patients often develop localized bone marrow edema and rapid focal osteopenia due to the profound vasomotor changes.
Oh, okay.
Yeah. So bisphosphonates inhibit bone marrow cell proliferation, and they modulate the local release of inflammatory mediators like substance P. By targeting that localized bone turnover and inflammation, they significantly reduce the associated nociceptive signaling.
Makes perfect sense. We also utilize anticonvulsants and antidepressants, primarily gabapentin and amitriptyline, to stabilize nerve membranes and modulate descending pain pathways.
Very standard.
And for severe central sensitization, we use NMDA antagonists like ketamine infusions. Ketamine actively works to replace that magnesium plug in the NMDA receptors, essentially rebooting the spinal cord's wind-up state.
But here is the pharmacological trap for the exam: opioids.
Oh, huge trap.
Yes. A patient in agonizing pain makes an opioid seem like a very logical choice on a multiple-choice test. Do not select opioids as a primary definitive treatment for CRPS.
Do not do it.
The literature shows a distinct lack of robust evidence for their effectiveness in this specific sympathetically driven neuropathic condition, and they actually carry a high risk of hyperalgesia.
Okay, let's shift to procedural interventions. I want to look closely at sympathetic blocks. Lumbar blocks for the lower extremity, stellate ganglion blocks for the upper extremity. They are heavily associated with CRPS treatment, historically.
Very heavily.
Yet, the Cochrane reviews cited in our sources explicitly state they have low-quality evidence of efficacy. If the data is poor, why do they remain in the treatment algorithms, and what is the takeaway for the MCCQE?
Right. It's the exact kind of real-world nuance medical students have to navigate. Sympathetic blocks remain in the algorithm because they make perfect pathophysiological sense.
On paper, yeah.
Exactly. We know sympathetic afferent coupling is a primary driver of the pain. Theoretically, blocking the sympathetic ganglion with local anesthetic should sever that connection and break the cycle.
But the data doesn't back it up perfectly.
Right. Large-scale, randomized controlled trials simply haven't provided undeniable universal data to support them as a definitive cure. So for the exam, recognize them as a standard diagnostic tool and an adjunct to facilitate physical therapy by providing a temporary window of pain relief, but, maintain skepticism about their long-term efficacy.
Got it. And if the blocks in pharmacology fail, we escalate to neuromodulation for refractory cases. Spinal cord stimulation, or SES, is standard. But the sources highlight a newer modality, dorsal root ganglion, or DRG, stimulation.
Yeah, and the exam might test your knowledge of the ACCURATE study, which is a landmark trial comparing the two. DRG stimulation was found to be superior to traditional SCS in reducing pain and improving the quality of life for CRPS patients.
Why is it better?
Because DRG stimulation targets the primary sensory neurons in the dorsal root ganglion directly. It provides highly localized pain relief without the extraneous tingling or, postural variations that are often seen with traditional spinal cord stimulation.
Okay, let's cap off the management section with a crucial point on prevention. If a patient presents to the emergency department with a standard distal radius fracture, is there a pharmacological intervention we can provide to prevent this massive neurological cascade from ever starting?
Yes, there actually is. Vitamin C.
Just vitamin C?
Just vitamin C.
Yeah.
Studies have shown that prescribing 500 milligrams of vitamin C daily for 50 days following a wrist fracture significantly reduces the risk of developing CRPS.
Wow.
The mechanism is tied to its powerful antioxidant properties. Following a fracture, there's a massive release of reactive oxygen species. Ascorbic acid scavenges these free radicals, neutralizing them before they can trigger the severe microvascular permeability and nociceptive misfiring that leads to the syndrome.
That's such an easy, high-yield exam point, vitamin C. All right, let's synthesize this review session. If you're sitting to the MCCQE next week, lock in these core takeaways. CRPS is a clinical diagnosis defined by regional, disproportionate pain that outlasts normal tissue healing. Differentiate type 1, lacking direct nerve trauma, from type 2, which involves no nerve trauma. Memorize the Budapest criteria, the continuing pain, plus the required combination of sensory, vasomotor, pseudomotor, and motor signs and symptoms.
3 and 2.
Exactly. The diagnosis is clinical, so do not fall for the triple-phase bone scan trap. And management requires an early, multimodal approach utilizing graded motor imagery, targeted pharmacotherapy like bisphosphonates or ketamine, and advanced neuromodulation like DRG stimulation for refractory cases.
Mastering this topic equips you for more than just scoring points on Section S08. It really prepares you to be the kind of physician who validates and aggressively advocates for patients suffering from a condition that, historically, has been dismissed by practitioners as being psychogenic.
Oh, it's all in your head, right?
Right. And these patients are enduring a physically measurable, catastrophic rewiring of their nervous system, and they need a clinician who actually understands the biology behind their pain.
You will be the physician who recognizes the failing system and knows exactly how to stabilize the grid, which leaves a fascinating concept to think about as you continue your exam review.
Lay it on us.
We discussed how graded motor imagery and mirror therapy remediate maladaptive neuroplasticity. We are treating a deeply physical disease state simply by visually tricking the brain with the reflection of a healthy limb.
Yeah.
If we can reshape the brain's physical map of the body and reverse vascular collapse purely through altering visual input, what other chronic physical disease states might we eventually cure simply by changing the brain's visual perception of reality?
That completely redefines the connection between perception and physiology.
It's something profound to consider while you hit the books.
Mm.
Good luck with your studying.